Thank you so much. Thanks to all of you for having me and REGENXBIO here today. I'm going to talk to you a little bit about the investigational RGX-202 Affinity Duchenne study. This is a phase 3 trial in Duchenne muscular dystrophy. So let me make sure the slides. Okay. We have some forward-looking statements that our lawyers make us put out there. And I'll go on to the next slide. So a little bit about our company. So our vision is a world in which debilitating diseases can be treated with a one-time therapy, resulting in lasting benefits. And our mission is seeking to improve lives through the curative potential of gene therapy. I'll tell you about RGX-202. So RGX-202 is our gene therapy program focused on Duchenne. We are very committed to the Duchenne community. This is an investigational AAV gene therapy that is designed to address the lack of functional dystrophin. So we use an AAV8 vector and an SPC512 promoter. So I heard some folks prior to my presentation talking about the different vectors. So ours is AAV8. And the promoter is meant to get your transgene to the correct location. So this is a muscle-specific promoter. The unique part about the SPC512 promoter is that it's also a little bit smaller, so it gives us a bit more packing room for what we could put into our microdystrophin gene. And then this microdystrophin gene is a manufactured gene, and we packed in this unique part called the C-terminal domain. All of this together was thoughtfully put together for the purposes of trying to deliver the best microdystrophin gene to the correct locations with the least side effect profile. The C-terminal domain that's highlighted here is a portion of the microdystrophin gene that can anchor to the sarcolemma or cell membrane of the muscle cells. It's connected to a section called the dystrophin-associated protein complex. You could see it here kind of highlighted in gray. So I'll be able to talk to you a little bit about our phase 1/2 interim safety data. So we actually morphed over time. So we were a phase 1/2 study and then turned into a basket study, which is a phase 1/2/3 study. So I can report out phase 1/2 data here. The phase 1/2 portion of our study tested 2 dose levels. And the first dose level was the lowest effective dose seen in preclinical study, mainly done on mice. And the second dose is the highest dose that we were going to go to. And we decided to go up to 2 × 10^14 genome copies per kilogram because, again, in the mice, we saw that there may be a better effect with the higher dose of gene therapy. So we started off with the lowest effective dose, and we had a good safety profile. And then we actually consulted with an external monitoring committee to allow us to move on to the next level. And because of our good safety profile with dose level 1, we were able to move on to dose level 2. So you'll see different programs have different amounts of drugs that they're delivering. We're on the higher end, so we're giving 2 × 10^14 genome copies per kilogram. And you can look at the age range of the children that we've treated so far. It's between 1 to 12 years of age, and we've had no SAEs or serious adverse events, no adverse events of special interest. These are adverse events that we see as something that we're interested in as a company. No myocarditis, no myositis. The most common thing that we saw with the children who received our drug is nausea, vomiting, and fatigue. And that's often early in the first 2 weeks after dosing with the medication. Overall, we've been pleased with how well tolerated RGX-202 has been in the phase 1/2 patients dosed at both dose levels. We also check for biomarkers. So biomarkers mainly include, in this scenario, the biggest biomarker is the muscle biopsy. So in our study, we do require a baseline muscle biopsy and then a follow-up muscle biopsy at 12 weeks. And what we check is the amount of microdystrophin that we can quantify with something called a Western blot test. We can also check to see how many copies per nucleus of our vector we can quantify. And we can do something called immunofluorescence, which uses an antibody stain to see that where the RGX-202 has localized. Because sometimes you can quantify the microdystrophin, but you also want to make sure that the microdystrophin is getting to the correct place. So I'm sure you could read through these numbers. There's a lot going on here. I'm going to focus on our goal dose, which is dose level 2. And you could see between children ages 1 through 12, we have really good microdystrophin expression. If you look at the microdystrophin quantification, in the first slide on Western blot, that quantifies how much microdystrophin you have in the sample of the muscle tissue. There is a little bit of what we can see on average an age-dependent effect. Now, this is on a smaller group of patients, but still, this kind of is a reflection of age, possibly like having more muscle to transduce. And then additionally, we can also check the vector copy numbers. So how much drug is getting into here. So you can see between dose level 1 and dose level 2, there appears to be a bit of a dose effect where we can get more vector genome copies per vector genome copies per nucleus than at dose level 2 than we get at dose level 1. Again, reassuring us that going to dose level 2 is good. And then we have positive fibers. Our immunofluorescence is pretty stable, similar between the two doses, where we have a good expression. So if you look to the right here on our immunofluorescence staining, that red rimming is in one of our patients at 12 weeks. And basically what you would see in a child with Duchenne without any dystrophin would be that there would be no staining and it would be kind of black completely, or you may just see little fades of this red in between. So our pivotal dose again is 2 × 10⁴ genome copies per kilogram. So when we refer to pivotal dose, that's what we're talking about. And we showed that our participants demonstrate improvement in function and exceeded external controls at 12 months. So we are not doing a placebo control study. We have opted to compare our patients to external control. And what we're doing here is exact matching to external control groups. These are patients that have either been part of natural history studies or placebo groups in other clinical trials. And we compare how our kids are doing compared to baseline, which is where the blue box travels. So going from 0 to -7 in time to -0.6 in time to -0.8-ish in the time to stand is what the change from baseline is. But then when you compare to what you would expect in a child at 12 months, as we understand that our kids with Duchenne tend to progress over time, especially when they're older. And this original set of patients is actually predominantly 8, 12, and a 6-year-old. You can see that there's obviously the change from baseline, but the change from what you would predict, which is in the gray box. So the delta that you see listed here is the difference between what our children are showing at a year versus what you would expect them to show at a year. So we're still seeing improvement from baseline, regardless of comparing, but even when you compare to what you would expect for a child that age to show after a year has progressed, we're showing dramatic improvement. So there's time to stand improvement of 1.6 seconds, 10-meter walk run improvement of 1.1 seconds, the time to climb improvement of 1.2 seconds. We also do this assessment called the North Star Ambulatory Assessment. That is a composite score, and basically our kids, again, are showing, compared to external natural history controls, an improvement of 6.8 points. So we also show here something called a CTAP model. So CTAP is a kind of logistic regression model. This is like a calculation that was created based on all this data from this collaboration of folks to see if you could input, certain aspects of a child, for example, the NSAA, their BMI, or their combination of weight and height, for example, other baseline functions, what would this model predict? It could give you like a prognosis of where this child would be. And what you see in red is the CTAP model predicted change, that red line. What you see in yellow is the natural history external control predicted change. And then what you see in blue is how our patients are performing. So this is using the CTAP model, which is just available for the NSAA right now, just kind of further supports what we're seeing with our natural history data. So our phase 3 study, is affinity. So I'll give you some details on that. Apologies if you heard my dogs in the background. So this is a study that continues to enroll patients. We are enrolling up to 30 for an accelerated approval, and then our confirmatory study will go for up to 60 patients. And the inclusion criteria for this patient, and we're actively enrolling, and we're very thankfully available in Canada right now, which is amazing. We're so happy to be there. We're so glad to be collaborating with the amazing doctors you have in Canada right now. It's been a joy. So these are going to be, we're including boys who are ages 1 and older at screening. They should have genetically confirmed Duchenne muscular dystrophy, except for, and so that we will take any child with any mutation except for deletions or point mutations in exons 8, 9, or 10. And the reason for this is based on some historical data of adverse events that were seen in some children, particularly with 8 and 9 deletions. The reason why we exclude 10 for now is because we also think that that's a little bit of a high risk area based on our own internal analysis. Now you might say, why is it high risk? So the transgene that we deliver, the microdystrophin gene that we deliver, is delivering some components that kids might be missing. Well, probably they are missing. And some areas are more immune stimulating than others. And we think that one of the issues is your body also has a protein called eutrophin, which is very similar to dystrophin. And some of the areas in eutrophin that are dissimilar to dystrophin are in that region of 8, 9, and 10 in particular. So we don't want to introduce something that is super foreign just yet. Not that we're not thinking about dosing these kids in the future. We are 100% thinking about doing that. But for now, we're kind of being a little bit more conservative and cautious and making sure that our safety profile remains safe in kids outside of this kind of higher risk range. And then if we can establish that, we will definitely do our best to dose these patients in the future. We have a lot of internal advocates and external advocates pushing for this, and our heart's in it for sure to address this unmet need. But for now, because of this, we are not dosing kids with deletions or point mutations in 8, 9, or 10. If you do have a duplication in this region, you're fine. And again, this is because we don't want your body to recognize this transgene or microdystrophin as foreign and then essentially attack it. It's almost like a rejection of an organ transplant. You can go and speak about this for hours, and I'm happy to field any questions about this after the presentation. We also ask that the kids have no pre-existing antibodies to the AAV8 vector. For kids who are 1 to less than 4 years of age, you need to be able to complete a 10-meter walk without assistance and complete a rise from floor without assistance. You can be on a stable dose on or off corticosteroids for 12 weeks. So you can enter the study if you're less than 4 years of age off steroids. We would just ask that you remain off steroids for the 2 years where we do our assessments. And your weight has to be greater than 10 kilos. The reason for that is that unfortunately we do have to do quite a bit of blood draws in the children to measure safety of our drug, and there's a limit to how much you can take, and that limit is often dictated by the child's weight. So that's basically the lowest weight we could go to. For kids who are over the age of 4, you need to be able to complete a 100-meter walk without assistance and be on a stable dose of corticosteroids for at least 12 weeks and have a baseline North Star ambulatory assessment of greater than or equal to 16. Now, are we looking to dose kids who are non-ambulatory in the future? 100%. But again, being very cautious, especially with recent findings of safety issues in some non-ambulatory patients, we want to make sure that we're safe with our current regimen and our current patient population that's being treated, but we have every intention of trying to address that unmet need in other patient populations as well. Now, one thing that we do to really address the safety issue that's been an ongoing concern when it comes to gene therapy is a proactive immune modulation regimen. So most gene therapy programs will give prednisone by itself. So this is something that everybody's familiar with, but because you're often on it on a daily basis, maybe in addition to deflazacort or maybe vamorolone, which is coming into Canada soon, you have options of one of those types of corticosteroids. This is an additional extra dose of prednisone that goes on board. But we actually add an additional sirolimus. Sirolimus is something that we give, and it's temporary. We start around a week before you start dosing, and then we complete this by 12 weeks, and weeks 8 to 12 are a weaning off period. And this is to address the adaptive immune response to our gene therapy. So there's two types of immune responses that can happen when you actually are exposed to a virus, or if you get vector genome therapy. There's the initial innate immune response, which is like a very chaotic attack, an immune system, kind of going out, just shooting everything. If you think of them like soldiers, they're not really focused, they're not really targeted, they're just going out. They're like, something's not right, we need to attack it. Well, that innate immune response is the first line that typically happens within the first 2 weeks. But then you get the more sophisticated troops coming in. Those sophisticated troops are the adaptive immune response. The innate immune response has a few risks during that time period. That includes thrombotic microangiopathy, which can cause kidney failure, and thrombocytopenia, which is low platelets, and obviously bleeding risk. And then the adaptive immune response can manifest as either a myositis or muscle inflammation or myocarditis or heart inflammation. So the sirolimus is meant to kind of target those more sophisticated troops. The eculizumab, which we give at about 5 doses to the patients, is to attack that initial kind of crazy attack on anything and everything that's not as sophisticated. And these are all temporary. And this is because we see the gene therapy as a very serious intervention that we want to kind of not want to play catch up with to try to suppress some kind of an adverse event that happens, but actually address it before it happens. So it's a little bit more intervention, but honestly with the goal of keeping a good safety profile, which we've seen so far. The pivotal trial endpoints. So the primary endpoint of our phase 3 study is going to be the proportion of our patients with greater than 10% of RGX-202 microdystrophin levels. And that'll be supported with functional assessments, which include our timed function tests, such as time to stand from a supine position or laying down on your back and then getting up to standing and how quickly you do that. The North Star ambulatory assessment in our 4 and older patients. We're also checking the Peabody Developmental Motor Scale, which is another motor function outcome measure for the less than 4-year-old patients, and the stride velocity 95th centile, which is immeasurable for all of our patients. It's listed as a secondary endpoint for the less than 4-year-old patients, but it'll be exploratory for the 4 and older patients. We're also doing MRI studies of the skeletal muscle and heart muscles as part of our trial. So again, we kind of went through some of this prophylactic immune system modulation that we're doing. So as I mentioned before, we give the viral gene therapy, you trigger an immune response. Everything kind of goes crazy for the innate immune response. Your complement system gets activated. And as I mentioned before, this can cause thrombotic microangiopathy, thrombocytopenia, which is the low platelets, liver injury, acute cardiac injury. And then you have your adaptive immune response, which is your B cells and T cells, which are more targeted. And these antibodies come to not just the vector itself, which is the AAV8, but also the transgene that you're giving. And that can trigger myocarditis, myositis, and again, another type of liver injury. So we hope with our eculizumab, which we give 5 doses, it ends on day 12. We give that 2 doses prior to your RGX-202 and 3 doses after. And then we give the sirolimus again, weaning between 8 to 12 weeks, a total of 12 weeks. And this is in addition to the steroids. We do all of this to prevent having any of these immune responses that can kind of make things go a little sour after you give gene therapy. And we're very happy with the response that we've seen so far. So we see it as a good investment of time and effort, and maybe it's a little bit more annoying with some of the additional medications that you have to take. But as I said, gene therapy is a serious process, and we're doing our best to not have to play catch up afterwards. So here are a list of the sites that we have in the United States. They're all across America. We're actually trying to open even more. We're getting really excited. We have a great network of physicians working with us here. And now we have Canada. We're so happy. So we have Dr. Selby And these are the ones that are open right now. Dr. Selby in BC Children's, Dr. Campbell in Children's Hospital London Health Center Science Center, and Dr. McMillan in CHIO. And I know we're getting Dr. Gonorowski up and running very soon as well. So we're super excited. So the phase 3 portion, as I mentioned, of Affinity Duchenne is an open label study. Everybody will get drug. There is no placebo group. We're testing RGX-202, and it is enrolling and continuing additional enrollment to support a confirmatory trial. As I said, we're enrolling up to 30 for our accelerated approval with the United States, with the FDA, but we will blast right past that. There's going to be no halt. We're going to continue on through the confirmatory enrollment of at least 60 patients. If you have any questions or you want to talk to your doctor about this trial, please go ahead. You can also visit clinicaltrials.gov. We also have a website called www.REGENXBIODMDtrials.com. You can also speak to a patient navigator to help verify whether or not your child might be eligible for the trial. That's mytomorrows.com/affinity-duchenne/en-us. And you can also contact our patient advocacy team, Duchenne@REGENXBIO.com. This is our website, REGENXBIODMDtrials.com, and here are our QR codes as well. Thank you so much.